Welcome to the last topic of Block 2. Once we've defined what is to be evaluated and identified the appropriate questions, you now need to choose the design best suited to answering those questions. Evaluation design refers to the way we approach the evaluation, the things we look at and the points in time that we do this. This diagram can be used to explain the different types of evaluation design. Here, time refers to the time period before to after the intervention has been initiated. The red box represents the intervention to be evaluated, and by now you should know exactly what this involves. And the arrows show people who do not use the intervention before entering the box, then they use it and are inside the box, and then they stop using it and are outside the box once more, or alternatively have just been inside the box for a certain amount of time. One of the most commonly used types of evaluation is audit. Many of you will already be familiar with this, and as already covered in Block 1, in an audit we look to see whether or not an intervention is being delivered according to established guidelines. In other words, we compare what goes on inside the boundaries of the intervention, as represented by the box, with what should be happening according to preset standards. The second type of evaluation is descriptive. As described in Block 1, process evaluations aim to answer questions related to how the intervention works or operates. Process evaluations can be used to feed back information in real time to improve or to adapt the delivery of your service, in which case it would be formative. Process measures might include activity data, numbers seen, whether it's working according to plan, but also getting feedback from staff, service users and so on, to understand in more depth how various stakeholders experience the intervention. A little bit more complex is to carry out a before and after comparison, for example to look at the impact of our intervention. This involves comparing outcomes before and after rollout and is straightforward as long as the baseline measure is taken before starting the intervention. This approach is generally used more in summative evaluations once the interventions have been designed and implemented. This approach is most commonly used as it's straightforward and not so resource intensive, but it can lead to bias. You cannot be sure if you see improvements after compared to before that they would not have happened anyway. And also there's a tendency for measures taken to become less extreme and returned closer to an individual's average value when measured another time due to what's termed regression to the mean. For example, this is one reason a GP might take a pulse more than once to record a patient's blood pressure. Finally, getting even more complex. Comparing the effects of your intervention with a comparison group, which has not received the intervention, will help you to understand whether any change can be attributed to the intervention or to other contextual changes that were occurring during that same period. By measuring outcomes before and after the intervention or standard care in the two groups, you can determine whether any change seen in the intervention group was greater or otherwise different to what would have happened anyway, so increasing the confidence that it was the intervention that made the difference. Make sure though that you avoid biasing the results by minimising the baseline differences between the two groups. Lastly is a randomised control design, where some service users receive the intervention and others don't. Unlike the previous design, here individuals, groups or locations are randomised into one of the two groups. This minimises the risk of selection bias by reducing the chance that people are entered into a particular group for reasons which might be linked to the outcomes, and ensures that the two groups are similar in baseline characteristics. As before, measurements are taken before and after the intervention and compared between the two groups. While often touted as the ideal or the gold standard, RCTs can be very expensive and complex to design and carry out. It's not always possible, desirable or even ethical to assign whether people receive an intervention or not. And furthermore, an RCT can sometimes affect both the intervention activity and the context in which it occurs, so that the findings may not be generalisable when the intervention is enacted in real-life situations outside of the rigid protocol of an RCT. When choosing an evaluation design, it's useful to think about what stage of the development your intervention is in. Depending on the stage of the intervention development, evaluation may be carried out for differing purposes. For example, in the very early stages, an evaluation may simply determine feasibility and acceptability of a planned intervention, while in the later stages, we are ready to roll out the intervention across multiple sites, the evaluation may be more driven towards understanding what factors influence implementation in different contexts and whether or not the intervention is sustainable, and so on. Not only will the stage of development influence the purpose of the evaluation, it will also influence the design of the evaluation utilised, becoming more complex and resource intensive the higher up you go up the intervention development stage. In general, those evaluations designed to assess interventions during their design or development phases are described as formative, and may influence the way the intervention is carried out, providing feedback along the way. In contrast, summative evaluations are those which assess interventions at the end of their operating cycle, once they've already been implemented. Findings from these are often used to determine whether or not to continue the intervention. The final practical of Block 2 is to complete Proforma Section B and to sketch out your evaluation design as illustrated in this topic.